Hello, everyone. I'd like to get the meeting under order here, please. We're going to continue today with our meeting on the study of the opioid crisis here in Canada. And I'm going to get right into it quickly here because we've got a lot of work to be done today. I'd like to introduce our panel this morning. We've got from the British Columbia Coroner's Service, we've got Lisa Lapointe, who is our Chief Coroner. Thank you, Lisa, for coming. We also have from the British Columbia Ministry of Health, we've got Bonnie Henry, and Bonnie is the Deputy Provincial Health Officer there. Thank you, Bonnie. And we've got David Yearlink. David is with the Sunnybrook Health Science Centre in Toronto. It's in Toronto, I assume. Yes, pardon my ignorance there. David is the head of the Division of Clinical Pharmacology and Toxicology at Sunnybrook. From the Drug User Advocacy League, we've got Sean LeBlanc, who's the founder and chair. Thanks, Sean. And we've got Catherine Haskell, who is a community organizer and a research assistant. Thanks, Catherine, for coming. All right, well, let's get right down to it here. We'll start with the British Columbia Coroner's Service with Lisa Lapointe. Thank you, Lisa.
Good morning. Thank you for having me. It will be a challenge to confine myself to 10 minutes because there's so much to say about this crisis that's happening, but I will do my very best. So I'm going to tell you a little bit about the Coroner Service investigation so you have a bit of an understanding on how we gather this information, some highlights on the data, the collaborations that we've developed in BC in an attempt to reduce the number of deaths that are happening, and then some of the strategies that we've developed moving forward. So one of the key points is the importance of thorough death investigations. If you're not doing the investigations and gathering the information, of course you don't know you have a problem, and that sounds very common sense, and I'll talk about that in a minute. And then strategic surveillance. Again, if you're not doing the surveillance on the deaths, you don't know you have a problem. And it's interesting to see across the country the different surveillance and reporting that's happening on these types of deaths. So the BC Coroner Service has 90 coroners across the province. The coroners actually respond to all sudden unexpected deaths. So they go to the scene of death and they do a thorough investigation that includes an examination of the deceased, an examination of the scene, and then collecting the medical history of the deceased. And that information is critical in determining next steps. If you don't have the suspicion that this death may be linked to drug use, then you won't order the appropriate testing, and then you won't have the appropriate results. So that sounds really common sense, but really the importance of the thorough scene investigation of each of these sudden unexpected deaths. As I say, the coroners are 24/7. That's important. People die all over the province, different times. We have a very clear investigative protocol, and that ensures that the consistent information is collected in every death. Again, critically important if you're looking for patterns. We also have in BC a dedicated research unit, and again, that seems common sense, but unless you make a decision to do surveillance on a type of death, you won't have the data. And across the country it varies. So every province and territory does something different. In BC, we decided to do some pretty focused surveillance on our drug deaths, and that's resulted in the data that we now have and that we've been able to share publicly. But those are strategic decisions really that can be made death investigation by death investigation, province by province, and it will vary across the country. One of the things I wanted to talk about, we have always heard the term overdose, and in my coroner service, we're starting to shift our terminology because overdose suggests that there's a safe dose. It also has a bit of a pejorative tone that perhaps if the user had used the right dose, they wouldn't have died. And in fact, that's really misleading because for many of these drugs, there is no safe dose. So overdose suggests that there's a safe dose. There isn't. And we really want to move away from that. So our reporting from now on will no longer talk about overdose deaths. All of these drugs, the opiates and the non-opiates, all of the illicit drugs are manufactured in very suspect circumstances, and you never know what's in the substance that you're taking. I also wanted to make clear, although I know the meeting today is focused on the opioid crisis. The deaths that we've been reporting are not just related to opioids. So BC's reporting on illicit drug deaths includes opioids, heroin and fentanyl, for example, but also includes other illicit drugs. So that includes cocaine, MDMA, which is ecstasy, and methamphetamines. So our illicit drug numbers that you're seeing, the high numbers going up month by month, that's illicit drugs. That includes all of those substances, not just opioids. It also includes prescription medications that have been diverted. So there is a small market for people selling their prescription medications, but we're not seeing a lot of that in this crisis. So toxicology testing, again, critically important. If you haven't identified that illicit drug use or any substance use may be a factor in the death, then you wouldn't order the appropriate testing. So again, speaks to the importance of the initial investigation and then the toxicology testing. We have something in British Columbia called expedited toxicology testing, which means our provincial toxicology center will give us results within 48 to 72 hours. That doesn't happen elsewhere in the country. I've spoken to my colleagues at the chief coroners and chief medical examiners across the country, and they don't have that ability. So that expedited toxicology, the ability to get information back from the lab very quickly, is really key in getting the messaging out in a timely manner. So I think you know, we've so far had in British Columbia, to the end of August, we've had 488 illicit drug-related deaths. And that compares to 505 for the whole of last year. Just to give you a bit of context, the whole of last year, British Columbia had 300 motor vehicle incident fatalities. So this epidemic of deaths is much more significant than the deaths that we're seeing on our roads, which we have numerous strategies in place to try to resolve. And we're seeing approximately 61 deaths a month due to illicit drugs. If that number continues to the end of the year, then we'll have 732 deaths for 2016. And that's quite a significant increase. We've seen a significant rise starting in 2012, which is ironically when we first saw fentanyl appear on our horizon. Primarily, the deaths we're seeing, although we're seeing deaths all ages, but primarily the deaths we're seeing are males between the ages of 19 and 39. Most of the deaths involve those who use illicit drugs habitually, but we have seen deaths where it's recreational users, people who all use at a party, and we've had situations, in fact 2 or 3 in the last couple months, where 5 or 6 people at the party have become overdosed, for lack of a better term, become very ill and been treated, and in most of those cases they have all survived. We've had 1 or 2 fatalities. So just to say that generally it's people who use drugs habitually who we are seeing among the deceased, but we are also seeing some recreational users. And then there are a number of people who use drugs quite consistently, but what we would call sort of high-functioning users, and that sounds pejorative and I don't mean it to be, but people who go to work, they hold steady jobs in all sorts of occupations, but they routinely use illicit drugs, and there's a fairly significant population there as well. Most of the deaths that we're seeing involved mixed substances, so very few involve just heroin or just fentanyl or just cocaine. In fact, we looked at 207 results recently, and 96% of those were mixed drug deaths. So cocaine was involved in 46%, alcohol 36%, methamphetamines 34%, and heroin 30%, and that was with fentanyl. The proportion of illicit drug deaths where fentanyl has been detected has grown substantially since 2012. We saw 5% of our illicit drug deaths in BC involving fentanyl in 2012. That's up to 60% in 2016, 6-0. So that's a significant increase. Now, that's not to say that fentanyl is the cause of all of those deaths, but fentanyl was detected in the toxicology results of all of those deaths at varying levels. And if there was no fentanyl, we don't know how many deaths we would see. If we removed all the fentanyl deaths, we would have at least 200, but our numbers for previous years would suggest that would be between 200 and 300. So fentanyl is doubling. The involvement of fentanyl appears to be doubling the deaths that we're seeing. I'm not going to spend any time talking about what fentanyl is. I think you know that. It's a synthetic opioid used traditionally for pain management. It's become increasingly prevalent on the illicit market. It's either brought in from other countries, primarily Asian countries, but it's also manufactured in clandestine labs in BC. When you think of a lab, you tend to think of white coats and sterile circumstances. And in fact, these labs are people's kitchens and people's basements, and they are quite random in a way. I mean, they're trying to measure substances and they're trying to be appropriate in what they put, but they're blending them in juice blenders and mix masters, and the compounds are really by no means secure or safe. So these labs are often, as we can see with the number of deaths, getting their mixtures wrong. And police are well aware of that. They're finding the fentanyl in pill form, in liquid form. It's used in a variety of ways. So what we're experiencing in BC are deaths due to illicit drugs, including a significant percentage of fentanyl. We're often seeing unsuspecting use. People think they're purchasing cocaine, for example, and it's laced with fentanyl. And they're either becoming very ill, being treated and surviving, or they're dying. We found a little bit of the paradox of warnings, and we've tried to work very closely with our police community on this. The language around this epidemic is very important, and we've had our law enforcement partners often wanting to go out and say there's very strong heroin on the street, or fentanyl is very strong or powerful. And those words can be triggers, in fact, and paradoxically, we now have people actively seeking fentanyl because of the bigger high. And it's really important to remember that. We should be talking about the risks, the toxic effect, but not necessarily that this is a more powerful drug or a stronger drug. We're seeing more analogs. Okay, so I'll wrap up. One of the really important things in the messaging, and we've gone out with public messaging, again, talking about what to say, what not to say. In BC, we've adopted a very much a harms reduction approach. Shaming and blaming doesn't help. We want to ensure that people, if they're going to use, have medical assistance nearby. That's the biggest message that we're giving. Don't use alone. Have somebody there who can help you out if you get into trouble. And we have a multi-sectoral partnership, but for the collaboration of a variety of groups, we wouldn't have been able to approach this crisis the way we have, where we've got BC Ambulance, the health communities, the coroner service, law enforcement, the labs, all working together to try to collaboratively come up with solutions. And one of the small changes, not small really, BC Ambulance has adopted a policy not to call police every time they respond to an overdose. Again, wanting people to encourage people to ask for help as opposed to being afraid that they're going to be arrested or somebody's going to be in trouble. So just that shift towards preventing deaths.
Great.
Thank you.
Thank you, Lisa. We'll move on quickly here to Ms. Bonnie Henry, who's the British Columbia, she's in the Ministry of Health there. She's the Deputy Provincial Health Minister. So go ahead, Bonnie. Thank you.
Thank you. I'm the Deputy Provincial Health Officer, so
Officer,
not the
Deputy
Minister. But merci beaucoup. Merci beaucoup de me donner l'occasion de vous présenter.
Thank you very much for this opportunity to introduce you to the situation in British Columbia and what we're trying to do to reduce this tragedy.
That Lisa has talked about, and I'll see if I can make this work. So this is a response that, as our coroner has indicated, that has been across the health sector and also public safety in BC. And this is the first time that we have used the Public Health Act in BC to declare an emergency, and the Provincial Health Officer, Dr. Perry Kendall, declared an emergency on April 14th of this year, when we started to see the dramatic increase in numbers of people who were dying from these overdoses. And what that allowed us to do was to collect information that we couldn't necessarily receive without this order, and it allowed us to get information in a more timely way and a more detailed way. And one of the things that we needed was to understand a little better who is being affected by this, and the data that we collect on people who are surviving overdoses is really important in helping direct our programs and our response to this as well. So we've started to receive data from emergency departments, from 911 calls, from our ambulance service around people who are surviving overdoses, and that has helped us look at how we can make naloxone, for example, more available, and I'll talk about that in a minute. We had on June an Overdose Action Summit where we had people from public safety, from law enforcement, from the health sector, people with lived experience, and the drug using people who use drugs. And we had a lot of brainstorming about what are the things that we can do to address the death crisis that we're dealing with, but then longer term to address the whole issue of overprescribing of opioids and the other factors that have led to some of the issues. We have developed new guidelines for prescribing opioids that came out from the College of Physicians and Surgeons in BC, and those are being looked at across the country. We have, with the help from the federal government, we've made it easier for doctors to prescribe Suboxone, which is a combination opioid substitution treatment that allows people to get away from the use of illicit drugs and gives them the opportunity to take a different path. And in June we had, or sorry, in July the Premier appointed a joint task force with health and law enforcement that's co-chaired by Dr. Perry Kendall and by Clayton Pecknold, who is our Chief of Police Services in BC. A couple of things that happened after that, Insight, which is, you may be aware, one of the only supervised injection service sites, it's a standalone site in the downtown east side of Vancouver, expanded its hours because of the data we were collecting that showed that we see peaks in overdoses and deaths around certain periods of time. We launched a public awareness campaign because, as indicated, it is not just people who are using drugs on a regular basis. There's many different populations who are being affected, including people who are prescribed opioids for very valid reasons, but in very high doses and an overdose on those. One of the big successes we've had is around expanding our take-home naloxone program. That was a program we started in BC about 3 years ago in 2012, and we have now distributed over 13,000 free naloxone kits. So these are for people who use drugs to help each other, and there have been many overdoses who have been survived because colleagues or friends or family members have used naloxone. And we now, thanks to delisting of the nasal spray and allowing the nasal spray naloxone to come in, we have police departments who are using it, and we have fire departments and emergency departments who are now providing naloxone and using naloxone to help. And just in September, naloxone was deregulated, so it now does not need to be prescribed by a pharmacist, and we can distribute it through many of our public health distribution places across the province. So this is the data that, I didn't realize I have to do both, so sorry. This is the data that the coroner described, where we've seen a dramatic increase in the last 2 or 3 years in overdose deaths. And the final column that you see on the far right is just until the end of August of 2016. And as you can see, we are on track to far exceed the number of deaths that we saw last year. And this reflects deaths. It doesn't reflect the fact that we're seeing hundreds of people in the emergency departments across the province who are surviving their overdoses. And that is a critical period of time where we can intervene, where people have an opportunity and a chance to get connected with, at the very least, to get naloxone and training on how to use naloxone. But it's an opportunity where they might be amenable to taking another path away from drugs. So I'm going to show just a series of maps that we have put together once we've started collecting more detailed data on where overdoses are occurring in BC. And this is to give you a sense of why this has been such a cross-government and a cross-province response. So this is rates by population, and the darker the red, the higher the rates. And this is from the distribution of illicit drug overdose deaths in British Columbia in 2016 from January to March. And the comparison is 2010. And in 2010, what we used to see and what people typically think of is the downtown east side in Vancouver. But what we're seeing now is it's happening across the province in communities everywhere in BC, in the north, in the interior, the island, not just the downtown east side in Vancouver, and in Vancouver, not just in the areas that we have seen it in the past, but all around Vancouver. People are dying in public places and they're dying in their private homes. This is some of the information that Lisa presented as well, just in a pictorial form that shows you the percentage of these illicit drugs illicit drug deaths where fentanyl has been involved, and it's dramatically increased from less than 5% in 2012 to over 60%. But as she indicated, these don't happen in isolation. Alcohol is very frequently a factor, and other drugs as well. And it has been somewhat alarming in that most people who we hear from our community members who are partners in this response that there's very little heroin left in BC. It's all illicit fentanyl that's been easily imported, much more easily imported than to bring into the country than heroin, because you need such a small amount, and so drug dealers are looking at maximizing their profits. It's easier for them to manufacture it and to bring it in than it is heroin, so there's very little heroin left. But more disturbingly, we're now seeing it mixed with stimulants like cocaine, where people do not necessarily expect to find a depressant like opioids, like fentanyl, mixed with those drugs, and are not necessarily prepared. And that's where we're seeing clusters of overdoses in people who are weekend users of cocaine, for example, where they don't have naloxone, they don't have the training about what to look for and how to respond. As indicated, most of the deaths that we're seeing are young men, and many of them have been people who have been using drugs for some time. And it's really a case of roulette, if you will. If you're using on a regular basis, your chances of getting a toxic dose of fentanyl just goes up that much higher. So every day that we can keep people alive is a day that they may move on a different path. So this is a description. You can't read the boxes, but this is how we have organized our response. And so we have a joint task force that reports up to our Minister of Public Safety and Solicitor General and the Ministry of Health, the Minister of Health, and it's chaired, as I mentioned, by Dr. Kendall and Clayton Pecknold, who's our Director of Police Services in BC. We have a large group in the middle, that pink box, of people who are stakeholders in this response, from law enforcement, from health, but also people with lived experience, families of drug use, the drug-using community, people who use drugs. And they give us very valuable advice about the issues that are happening on the street, and also about our response and what makes sense and what doesn't make sense for them. So it's been an invaluable group to help us in shaping what we can do. And then we have a number of task groups, and I'll talk about some of the things the task groups are working on. Our immediate sort of 3-month work plan has a number of specific issues. I have the French one in front of me, so I have to put my notes up here. One of the biggest things that we wanted to do to initiate was expand the reach of naloxone. So that being deregulated at the federal level made it non-prescription, and that has been a huge help for us in that. We now have an intranasal formulation which is available, and particularly for law enforcement who didn't feel comfortable using the injectable form. Most of it is the injectable form, and we have lots of good evidence that the injectable form works well. And people can very easily learn to use it. We have some some videos that we've developed for young people in particular that are entitled Naloxone Wakes You Up, and it tells them how to use it. I'm happy to share those with people. We've done a lot of work around opioid substitution treatment and making it more available, teaching physicians how to use it, and particularly Suboxone, which is a much safer form of opioid substitution treatment, taking and delinking it from the methadone programs that we've had in the past, and we've expanded the use to nursing practice so nurses can monitor opioid substitution treatment as well.
Great.
Some
Bonnie.
of the other areas that we're...
Bonnie, excuse me, I'm going to give you about another minute if you don't
Yep,
mind.
I'm
We just
on
have
my
to move
last
on.
slide.
Okay, thank you.
Some of the other areas we're expanding around drug checking, the ability for people to check their drugs to see if there's fentanyl in it prior to taking them, and there's some legislative barriers for those. Monitoring and surveillance, increasing our access to supervised consumption services around the province, and that, again, there are some legislative barriers at the federal level that could be helpful in that. And we are doing quite an extensive public education and awareness campaign around both illicit fentanyl and what to do about it. And this is just a graph that shows the number of naloxone kits we've distributed in the province. So to sum up, there's a couple of things that we would like to bring to your attention. The province would like support in expanding our supervised consumption services, and in particular, the Respect for Communities Act has a number of barriers that are quite extreme that we would like to see reduced or eliminated, and we understand there's a need to make sure that these safe consumption services are developed in a way that is safe and that has community support, and we have ways of doing that that we think can meet the spirit of the bill without the extreme barriers that Bill C-2 puts in place. We would like to work with the federal government to ensure the granting of exemptions under the Controlled Drugs and Substances Act for the purpose of drug checking, which is something that we think can be an important service in helping people understand what they're taking prior to. And we want to increase availability of treatments for opioid use disorder, particularly some of the longer-acting, more effective treatments that are available south of the border. And we know some people in BC are being able to access south of the border. So again, those are areas that we can get your help on. We'd be appreciated. So thank you very much for your time today.
Excellent. Thank you very much for that, Bonnie. I will quickly move on here now to David Yerlich, who's with the Sunnybrook Health Sciences Center. Thanks, David.
Good morning. Thanks for the opportunity to present. By way of introduction, I'm a physician. I specialize in internal medicine and pharmacology. I'm not a specialist in addiction. I'm not somebody with extensive public health training, but I do a fair bit of research in the field of drug safety, and over the last 7 or so years, this problem has become a major preoccupation of mine. And I'll just share with you some reflections on the problem as I see it. I apologize if some of these things are things you've heard before. In the early 1990s, I was a pharmacist in Nova Scotia. I trained there, and during medical school and my internship, I practiced as a pharmacist, worked at about 36 pharmacies across the province. And it was the case that when a patient came to the pharmacy with a prescription for morphine, they had cancer. By the late 1990s, when I was finishing my internal medicine training, things had changed quite a lot. We saw OxyContin, a drug that is 1.5 to 2 times more potent than morphine, prescribed very liberally for chronic back pain, hip pain, osteoarthritis, fibromyalgia, you name it, doled out for minor ankle injuries. And this happened because physicians were taught that it was safe and effective to use opioids for chronic pain. Most physicians had no reluctance to give opioids to patients at end of life, or patients who got a bone sticking out of their femur, or their femur sticking out of their leg. But the chronic pain market is huge, and doctors were faced with, every day, patients with pain, and we had reluctance to use the other drugs at our disposal. Acetaminophen, Tylenol, this doesn't work very well. The other drugs, anti-inflammatories, had all kinds of horrible side effects. We've all been burned by patients who'd had bowel problems or kidney problems as a result. So the message that we could use these drugs, and we should use these drugs more liberally, was one we were quite happy to hear. The important thing to realize is that message came directly and indirectly from the companies that made these drugs and have subsequently earned tens of billions of dollars from selling them. They sent drug reps to doctors' offices, but there was much more than that. There were key opinion leaders in the field of pain all across North America, giving talks at CME events, continuing education events, at fancy restaurants. I went to them myself, and I was told that not only should you use these drugs, but if you didn't use them, you were opiophobic, and you were depriving your patients of a proven therapy. The virtues of these drugs were extolled. The companies made their ways in some instances, including at my own medical school, into the curriculum where individuals in the pay of the companies that make these drugs taught for years, medical students, without disclosing their conflicts and giving them overly rosy views of the utility of these drugs. As I said before, for many of us, this was a message we were quite happy to hear. We now, however, realize that with the benefit of hindsight, that we should have known better. I can tell you that there are no good studies showing that opioids used in the long term improve patients' outcomes. I mean, the overarching goal when I prescribe a drug to a patient is to give more benefits than harms, and there's never ever been a study that shows that in the long term this happens. Most of the studies, by the way, they go for 8 or 12 weeks. They're in very carefully selected patients who have no risk factors or as few risk factors for addiction as you can find. And they're not on benzodiazepines. They've got no mental health problems. They've got no history of trauma as a child. And they show that over a couple of weeks, these drugs will lower pain scores. The fact that there are no long-term studies didn't stop Health Canada and the FDA from approving these drugs for long-term use. And we've now seen what amounts to a 20-year experiment on the population. We've seen and we know that the beneficial effects of these drugs very often wear off, and going up on the doses doesn't solve this problem. All it does is add to the toxicity. Virtually everyone who takes these drugs daily is dependent on them, making for a self-perpetuating therapy. You can't stop these drugs. Even if the pain-reducing effects have worn off, stopping the drugs will make you sick, and it will lead patients to perceive that the drugs are needed. Patients need the drugs just to feel normal. Critically, we were taught that addiction was a rare consequence of using these drugs long term. Less than 1%, I remember hearing the words, less than 1% of patients would become addicted. That's not true. The best estimate at the moment is somewhere in the order of about 10%. I mean, just imagine that. You know, hundreds of thousands of patients in Canada on these drugs, well-intentioned prescribing, and 10% of them may be spiraling into addiction. We also know that high doses kill people, and we see, I can't tell you how often I see patients coming under my care who are on hundreds of milligrams of morphine or equivalent. We did a study in 2015 that made very clear that people on high doses of opioids were more likely to die from their medication than almost anything else. When we talk about addiction and death, there's a lot more to it than that. You know, the death toll in Canada, as I'm sure you've already heard, is not known. BC is on track, it sounds, for about 700 deaths with a population of around 4.7 million. That places it up there with Alabama, the worst state in the U.S. in terms of rates. But when you think about it differently, I mean, we published a paper in 2014 that looked at deaths in Ontario, and we found that 1 out of every 8 deaths in people aged 25 to 34 involved an opioid. That's a staggering number. And when you total the deaths from opioids in Ontario, the total person years of life lost, remember, these are people dying in their 20s and 30s and 40s who should have lived to their 70s and 80s and longer. The total years of life lost is somewhere in the order of 1/13 of all years lost from cancers, all cancers combined. There are other harms here as well. Motor vehicle collisions. I mean, people driving under the influence of opioids are at risk for collisions. We've shown that convincingly. Falls. I all the time see older people who are on opioids for chronic pain, often not benefiting as far as I can tell, who fall and they break hips and they break their necks and they have head injuries. Constipation sounds like an annoyance. I have had more than one patient die under my care from constipation caused by these drugs. It might seem counterintuitive, but these drugs can actually worsen pain itself. As the doses go up, the pain gets worse. It's because of the drugs. These drugs disrupt sleep. I am convinced they cause in some people depression, and I suspect in some people they cause them to commit suicide. And those suicides are very often blamed on the pain rather than the drugs themselves. There are other epidemics here. Neonatal abstinence syndrome. In Ontario, from 1992 to 2011, the number of babies born dependent on drugs went up 15-fold. And this, that's just from the prescribing. The proliferation of tablets, our well-intended prescribing of drugs, has left every medicine cabinet in Ontario has got some opioids in it. It's a bit of an exaggeration, but those drugs are there for people who might want to experiment. A 16 or 17-year-old who's curious and finds themselves spiraling into addiction. The epidemic has transformed over the last couple of years, as you've been told. It's not just about OxyContin and Dilaudid and so on. It's now about fentanyl and heroin. Those drugs have been used for a long time. But there is a market that's been created in response to our well-intentioned prescribing that did not exist to anywhere near the same degree in the early 1990s. This was a crisis that was largely created by physicians. And it has to do with the fact that opioids, once started, are hard to stop. It was exacerbated in 2012 by the reformulation of OxyContin. Purdue took off their old product, put on a new product that was tamper-resistant, and we found a lot of people going to heroin and fentanyl as a result. And fentanyl, I mean, the importance of this can't be overstated. I mean, you can get a kilogram of fentanyl from China for $10,000 or $20,000, and it fits in a shoebox, and you can turn it into $20 million of profit. So that's not ending up, as you've heard, just in heroin. It's ending up in fake OxyContin tablets. It's ending up in cocaine. It's ending up in meth. It's ending up in fake Xanax tablets. The scope of the problem in Canada is completely unknown. I mean, we know in the U.S. the CDC estimates that over the last 20 years, about 250,000 people have died from opioids, more than half of them from prescription opioids, and about 2.1 million people in the U.S. suffer from addiction. We have no corresponding numbers from Canada. I speculate that somewhere in the order of 20,000 Canadians have died over the last 20 years from these drugs. And the fact that no federal politician can tell you what that number is a national embarrassment. This is the greatest drug safety crisis of our time, and it's not hyperbole to say that every one of you knows somebody with an opioid use disorder. Whether you realize it or not, you do, and it's quite possible that you know someone who's lost a loved one to these drugs. And yet, the Public Health Agency of Canada has been largely silent on this issue despite its mandate. The mandate, just to reiterate, is to promote and protect the health of Canadians through leadership, partnership, innovation, and action in public health. Go to the website, search fentanyl, you'll find almost nothing. Health Canada seems to have largely handed this file to CCSA, which I think is a good organization and has all kinds of potential, but it's not adequately resourced. And it's not focused exclusively on opioids. It's got alcohol and other drugs under its considerations. It has felt very much like no one is really in charge of this file, and everyone is keen to pass the buck to someone else. It's only recently that we've actually begun to see some federal leadership on this issue with the hastening of the move of naloxone to non-prescription status, reducing barriers to safe injection sites, which are very, very important, and this upcoming summit in November. So if I was to tell you what I think needs to happen to solve this problem, I think the response needs to be collaborative, it needs to be proportional to the scale of the problem, it needs to be urgent. If 30 or 40 Canadians were dying every week from Zika virus, your hair would be on fire with the scope of the problem. I mean, this is actually what's happening now. We need timely surveillance, not just in BC. It's the only province that's doing it in a timely fashion. We need it everywhere, and not just on deaths, but on non-fatal overdoses as well. Naloxone saves lives, and it should be everywhere. It should be in corner stores and gas stations for free. I think Health Canada has good grounds to revisit its decision, its indications for these drugs. There has never been a study, as I said, that shows that these drugs are safe and effective for chronic pain. I think that the label, the indication should be revised. And I think that when doctors choose to prescribe these drugs for chronic pain, they should do so off-label without an official endorsement from our national regulator. And I think we can give serious thought to removing market approval for the highest potency drugs out there. The fentanyl patches of 75 and 100 micrograms, and Oxyneo 80, and the highest formulations of Dilaudid. I think the provisions under Vanessa's law give the minister the power to do exactly that. We need to change how doctors prescribe. Doctors need to start these drugs less readily, much less readily, and escalate doses much less readily than we have. A whole generation of doctors has lost respect for these drugs, and we don't see them as we did 20 years ago. The education of physicians is important, but it's not going to solve this problem on its own. It has to be detached completely from industry and from pain specialists who take money from these drug companies. You'll see new prescribing guidelines for physicians coming out early next year. I'm on the steering committee for that. I think that will be helpful. But I think that the fewer patients who start on these drugs, the better. And the patients who are on very high doses need to be de-escalated cautiously and closely. But we've got a large swath of the population who now, we've got a minute left? Okay.
I'll give you a minute.
Okay.
Sure.
We have a large swath of the population with addiction, and I think it's very important that we perceive this as a public health problem, not a criminal one. When somebody goes and steals from a pharmacy or holds up a store, it's not because they're a bad person, it's a person who needs help. And many of these people want out. They need rapid access to opioid substitution therapies like Suboxone. They need access to supports. We need many, many more clinicians who know how to treat these people and ready access to them. And we need safe injection sites, and I think the point's been made that the Respect for Communities Act proposes a major barrier to the construction of these sites. So I'll just leave you with one last point, and I'll make the point, this is not your usual epidemic, right? No one ever argued for more Ebola or more Zika or more influenza, but there are forces at play who will argue that physicians should not prescribe differently, that we should need these drugs for chronic pain, and that I think is exactly the wrong message, and that message needs to be, those sorts of oppositional comments need to be disregarded. I'll leave my comments there.
Great. Thank you very much, Doctor. Very informative for sure. Now we have the Drug User Advocacy League. We've got both Catherine Haskell and Sean LeBlanc, so we've got 10 minutes. Thank you.
Thank you very much for, first of all, inviting me. I'm also, I'd like to mention, a peer support worker in the city of Ottawa, so I work pretty well firsthand and frontline with drug users, almost specifically opiate users on a daily basis. Dual is a nonprofit that was founded in 2010, which basically neither condones nor condemns drug use, but sees it as a facet of everyday society. People are going to use drugs, and we just try to best educate them about that. We've got several services, some of which Catherine runs a couple of our drop-ins, and it's just basically to provide a voice for people that do not have one. I myself am someone who has survived an addiction to opiates. I used opiates for about 15 years, and it is not a pleasant thing. It certainly isn't. Coming off of these drugs is extremely, extremely hard. I had pretty well a normal childhood and everything, and the last thing I thought I would ever be was someone that would inject opiates. Unfortunately, I suffered a few traumas during my teenage years, and I just wanted to basically end the pain. That's one thing I will give credit to opiates for, is that they help you to numb the pain. You know, not in any healthy or helpful way, but for someone who's really hurting, opiates, you know, do deaden that pain. Basically, my life pretty well spiraled after that. I ended up homeless, not much self-worth. Thankfully, I guess I got kind of a stubborn streak, and around in 2010, I started to do some advocacy and founded Dual out of that. It was basically the lack of inclusion which really wanted me to start Dual and create a voice for people. I started being on different committees and everything like that, and I'd always see, you know, some great doctors and police officers and epidemiologists, but there was never people that actually used drugs that were part of those committees. And if they were, it was usually in a really tokenistic way. This is why I'm so thankful to being invited here today, because those officers aren't usually around. And I think the best way we can get results to this crisis is working in conjunction with each other, the doctors, the coroners, the police officers, and more so than anybody, the people that use drugs, because they really are the experts on this. The Oxy crisis basically started right around 2010 in Ontario as well. As my fellow panelists have alluded to, it started basically created this whole desire, need for fentanyl and heroin. The drugs have gotten so much stronger, and so many younger people are using them now. It's just really, really scary. I think we don't want to get too far into that, though. These drugs do play a really good role in some people's lives. People are really suffering from great pain, and I've known people who cannot, you know, get relief from that pain because of the overprescription, the stigma associated with using these drugs. Like, again, I'm not condoning them or anything, but they do fill a role in our society. Some people need them, and I don't think we want to get too far away from that. Yeah, I'm just going to speak very briefly and very informally. Basically, my fellow panelists said everything I basically wanted to say on this. as I alluded to earlier a little bit about the detoxing off the opiates, when I first started to want to get off opiates, there weren't really any substitutes out there for me. There was methadone, but there was no treatment offered. I tried to get into a treatment center, and that was impossible. To this day, it's pretty well a roll of the dice if you can get into treatment or not. We really need to increase all different types of treatment, because right now there's basically one form, and that's detox, and that's it. And that's not going to work for everybody. Nobody ever wants to grow up to stick a needle in their arm or use opiates, but it's a facet of society, and I think we need to deal with it responsibly. Sorry. This is a medical issue, as some of my panelists have pointed out beforehand. It's not a criminal issue, and I think we need to continue to deal with it in that way. Almost all my recommendations have already been said by my fellow panelists here, but I think we really need to repeal Bill C-2, or at least different parts of it. Supervised injection sites, the Supreme Court came out unanimously in favor of the opening of, or the keeping open of Insight in Vancouver, and yet we've seen no other supervised injection sites in this country. I think, frankly, there should be one in every major city, if not several. You know, they've been shown to reduce overdose, reduce deaths, reduce the transmission of disease. Another thing that Dual does is go into schools a lot, but we're very, very limited in what we can say, especially in public schools. There's no harm reduction education. It's all abstinence-based. And a lot of people who are starting into drugs, specifically opiates, are doing so at that age. Those teenage years are extremely important. And we're not allowed to have an honest conversation with them. I think, you know, getting people while they're young and showing them that, you know, addiction to opiates specifically, nothing positive is going to come of that. You know, I think we can have some really good benefits with that. I think we need to be educating people who are being released from jail. Right now, there's a lot of overdoses for people being released. They'll get out, they'll use, and the same dose that they used before they went in, and this is enough to kill them. I'm sorry I'm so emotional, but these are my friends, people that I work with, people I love. I've lost my best friend to a fentanyl overdose. And it really, really hits home. In Ottawa, we see an overdose on opiates about every 10 days, and you know, that's just obviously not acceptable. I brought an naloxone kit here today, which has been really great. I've actually used it twice, and see it, basically pulled people right out of overdoses. The problem with these kits right now is that the dose of the naloxone is so low and the drugs are so high, it isn't actually counteracting the overdose as well as it should. So I'd really like to see the dosage of the naloxone, a very innocuous and harmless drug, be increased so that it can meet the demand that these drugs are putting out. I would also like to see and develop other forms of treatment. Right now, you know, even to get into somebody in the detox, I've got people approaching me every day wanting to clean up their lives per se, and we can't even get them a bed anywhere. It's just basically a luck of the draw. If you can get somebody in, great. If you can't, then that's it. And I think most important is that we need to continue to include people with lived experience and people that use drugs in these conversations. We have a wealth of knowledge that I think we can share, and as I alluded to earlier, in conjunction with scientists and doctors and everything, I think politicians as well, obviously, is that we can really get to the grips of this problem. There are solutions out there, and I believe that Canadians are really, what's what I'm looking for? That's what I'm looking for? Nurturing. You know, we really believe in healthcare. This is a medical issue, and I think we need to continue to treat it as such. There's a statement that we use at Dual and other drug user groups around the country that's nothing for us without us, and I would just like to see a little bit more inclusion at all levels, from the top to the bottom, because there are solutions to these problems. You know, we solved a lot of things with the oxy crisis, and I think we really can with the fentanyl crisis. So it's just, you know, let's just keep plugging away, and I think these problems can be eradicated really quickly. Again, I apologize for my emotion. My voice was breaking most of the time there, and I really, really appreciate the invite up here. So thank you very much.
Great. Well, thank you, Sean, and it's really happy to see that you're doing better. So, and thank you for your presentation. Sean, you do have a a minute or so, can I just ask you a very quick question about that naloxone kit there? How easy is it for you to get that and to distribute that to your patients, to your clients?
Well, I've now been trained as a trainer to be able to do it, but it took a lot of work to do that. We've only given out 250 kits, or Public Health, I should say, has only given out 250 kits in Ottawa over 5 years. That's like less than 1 kit a week. Now, there's a lot of pharmacies which are giving it out, which is really, really great. They're not training people maybe as well as they should be, and a lot of pharmacies still don't realize that they're able to get rid of it. So, yeah, as I think someone mentioned, there was 13,000 kits given out in BC. I think we can easily approach that in other provinces too.
Great. Excellent. Thank you, Sean. Well, we'll get into our questioning round here now, and we're going to start with MP John Oliver. John?
Thank you very much, and thank you all of you for your presentations. A lot of passion, Sean in particular, the sharing of your own personal story is much appreciated. So I just, David, I just want to confirm that I heard from you that 1 out of 8 deaths in Ontario involve opioids now, and that the years of life lost are greater from opioid deaths are greater than all cancer years of life lost. Did I hear that right?
Not quite. So we published a paper a few years ago that simply looked at all of the deaths that occurred in Ontario and looked at the deaths that involved opioids, and we broke them up into age ranges. And so I think the key finding there, other than the fact that deaths involving opioids have skyrocketed over the years, no surprise, is that in 2010, in the age group of 25 to 34 years.
You have 7 minutes, so get to the punch.
So that's the segment of the population where 1 in 8 people died of an opioid, young people, and that collectively all of the person years of life lost was about 1/13 that of all cancers combined.
1/13, okay, good. Thank you. Now, the Minister, I also appreciated, David, your comment that you've seen some federal leadership coming on this. So the Minister of Health has laid out a 5-point comprehensive federal strategy, better informing Canadians about the risks of opioids, supporting better prescription practices, reducing the access to unnecessary opioids, supporting better treatment options, and starting to gather the evidence and getting the evidence together. The naloxone availability was made possible, and the nasal sprays are now coming in from the U.S. And I heard a number of recommendations from you, so I think, and from Bonnie. So from Bonnie, you had expanding supervised consumption services. I heard C2 is a major problem across Canada. Establishing drug checking as a harm reduction service to make sure you can see what you're actually ingesting, even if it's illegal. Increasing availability of treatments for opioid use disorders. And then, David, I heard prescription changes, better education of physicians to make sure that the use of opioids are better managed. All of you referenced better surveillance, and we need a national surveillance program for this. And the dosage, I heard, Sean, the dosage of naloxone needs to be increased in some of these kits. Any other recommendations above those? I think as a committee, the Minister is convening a workshop in November, a special sort of consultation. Any other advice you'd give us to better this situation, or to give advice to the Minister?
We would recommend more regulation of the precursors, so the chemicals that are combined to make these drugs, greater regulation of those, certainly regulations around commercial pill presses. Those
on the Minister's list is they are they're working to add the chemicals used to make illicit fentanyl to controlled drug and substance acts. That's in the works.
Okay, and the commercial pill presses need to be regulated, and we would advocate the Good Samaritan law, which I believe has been introduced in the House. It's a small measure, but it will be a health response to overdoses. Police will no longer come, and again, that's focusing on the health as opposed to
the author of that bill is sitting at the table. So. Yes.
I said this in my comments, but I can't emphasize it enough. I really think that Health Canada needs to revisit its grounds for the indications for using these drugs. I mean, you find yourself in a hole, the first thing you have to do is stop digging, and unless we stop prescribing these drugs as we have for 20 years, this problem's not going to go away.
I would just like to see a little bit more increase in education, especially on public school and high school levels. Harm reduction, frankly, saved my life. Needle distribution of these kits, methadone, and we can't talk right now, frankly, because of a lot of school boards and everything, about drugs in a real sense. And I think some easing of those restrictions would be really great.
Okay.
But, federal enforcement and interdiction strategies around importation of illicit drugs. Anything we can do with CBSA, the Canadian Border Services Agency, to try and improve our ability to prevent these from getting in, and relationships with other countries where there's, particularly China, where there are a lot of these we understand are being manufactured.
Okay. And I think, Bonnie, you mentioned that you have you've launched social media and you're trying to get public awareness. What are the key messages that, particularly focusing on the young population that might be looking at experimental, recreational use of these drugs versus the other sort of categories? And what would the key messages be that you deliver to younger Canadians?
Yeah, well, number one is, that these are dangerous things and don't do them, obviously. But we recognize, as our colleague Sean mentioned, that especially young people are going to try these. So the messages are around how to look after each other, how to use naloxone. So we have a whole campaign around Naloxone Wakes You Up. So people understand the use of it. They understand and recognize when their friends are overdosing, when they need to call 911. We've done a lot of work with law enforcement in BC to make that a positive experience, so that they aren't arresting people when they respond to overdoses, which has been a problem, an issue in the past. We've involved a lot of youth in developing these tools, and as Sean mentioned, having people with the lived experience be involved in helping us speak frankly about these issues to children. And I would encourage people to go to towardstheheart.org. It's a website that we've developed in BC that is a collaboration with the people who use drugs, people with lived experience, the health sector, and we've got lots of tools there for young people, but for all age groups, around what to do, what the risks are, and how to respond.
Okay. And I thought you gave some excellent advice as well on not using words like powerful or impactful, or whoever, maybe it was Dr. Lapointe raised that point. And I had one last question for David, and fentanyl. So this epidemic of fentanyl in British Columbia was staggering. I think it went from 5% of illicit drug deaths involved fentanyl in 2012 to 62% by 2015. Are we seeing the incidence of fentanyl or the presence of fentanyl? Do you have any data on that in Ontario?
Well, in Ontario, it's roughly doubled over the last 4 years. In Alberta, fentanyl-related deaths have gone up, I think, about 5,000% over the span of 3 or 4 years. That's no longer the prescription stuff. It's the illicit stuff that's coming into Canada from China and being produced domestically to a certain extent.
Great. Mr. Earl.
Comment very quickly. There are scarier forms of fentanyl out there. In Ontario, we aren't even testing for them. I know they're around. I'm not looking for them.
Thanks, Mr. Oliver. We're going to move on now to Ms. Harder.
All right. Yes, thank you. I'm going to start off with with a question for Ms. Henry. You talked a bit about providing naloxone, and certainly I think we would all agree that that's a very positive thing to do. I guess one of my concerns, though, with that is we're also talking about testing for fentanyl being in these drugs that are being used, and we'd like to do that. So the combination of being able to test for fentanyl and providing naloxone kits, I would imagine that some drug users then would make the decision, regardless of testing for it and finding fentanyl, to go ahead and use anyways because they have access to naloxone. So I am concerned about that because it feels like that could actually perhaps perpetuate the problem rather than solve the problem. I'd be interested in hearing your thoughts on that.
Yeah. So I think you're absolutely right, and as a matter of fact, some people seek out the testing. We've heard that some of the dealers are actually sending people in to have the drugs checked because they don't want to be giving fentanyl to their cocaine users. Anyway, but I don't think it's an issue around perpetuating use. We did a pilot study at Insight, which is the supervised injection service site in Vancouver, and some people didn't test. People go to Insight because they don't want to die from their drug addiction, and it's an opportunity for us to intervene, to treat them with respect, to give them the chance to get off that cycle that they're in. So we don't see it as a way of perpetuating the use or encouraging people to use. What we find is every day they stay alive, it's an opportunity to get off of that cycle. And the naloxone keeps people alive. And what we're finding is that people will check their drugs because you have to use a bit of your drug. And if it's hard to come by and you're in that situation, you may not want to do that. And what we're finding is people will do it after they've overdosed to see if that's what was the cause of it.
Thank you.
So there's a little bit of, and it's a challenge still because the tests that are available for drug checking are not we don't know the parameters. They're not designed for drugs. They're designed for urine testing. But so we don't have good drug checking capabilities yet, but we're working on it.
Okay,
and
thank you. Now, another thing that's been said across this table here is there's an emphasis on safe injection sites, safe use, safe consumption, if you will. There's a focus on substitution treatment. I'm not hearing much with regards to detox or therapy treatments where we would want to see people actually off illicit drugs. Now, I am of the belief, and I would be interested in hearing your thoughts, I am of the belief that every single person on this planet is very valuable and born with incredible potential. I am also of the belief that that potential can only be fulfilled if that individual is given the opportunity to be healthy. It would seem reasonable for me to then believe that using illicit drugs certainly prevents that individual from being able to realize their full potential. So having that belief in mind, I am clearly an advocate for treatment that would help people get off illicit drugs and be able to step into their full capacity as people. So I'm wondering, why not focus on treatment? Why not focus on helping people overcome these addictions, which most of them probably don't want anyways, and help them step into their full capacity as people and reach that potential with which they were born? Why not take that approach and put our energy and our money toward that instead of these other things? Now, I understand that there are intermediate stages. I understand that. But I'm just wondering why that isn't a part of the conversation at this table. Ms. Henry, I'd like to start with you.
Large part of the conversation, and it is a very important part of our conversation, and I'm sure David will talk about this, but the challenge is that we need to have immediate actions to prevent people from dying so they can get to that point. And you're absolutely right, and Sean has said it, nobody grows up wanting to be addicted to these drugs and wanting to die on the street with fentanyl. You know, that is not people's aim in life. And we've found through Insight is a good example where we have Insight and Onsite. It's the treating people with respect, getting them to the point where they managing their addictions, where they're not dying from it, and they do make that shift and get into treatment, get off drugs. Opioid substitution, and I think one of the challenges we have is we're stuck in an anachronism around detox and treatment that is based on alcohol, and it's based on 28-day abstinence programs for alcohol, which do not work for opioids. The physiological dependence on opioids and what it does to your body and your mind is very different from alcohol. And opioid substitution treatment is a way of getting people off illicit drugs. Instead of detoxing, which puts them at great risk of overdose and dying and is very traumatic and difficult, the substitution treatment is not meant lifelong for most people. It's a period of time that allows you to get off the illicit drugs, to be substituted, and to then taper off those in time.
So, sorry, just in the interest of time here, I'm just going to interject there really quick because I actually had the opportunity to go to Insight during this spring. And I talked with the director there, and I asked him, is there any endeavor to help people get off drugs? And he said no. He said the success of their program is if they can help people inject safely, full stop. And so I asked, is there any partnerships with organizations?
Talking about was
just hold on here.
Philosophy in the site itself. But
so I further asked him if there was any partnership with other organizations that might help people, right? Because I understand different organizations can work together in partnership to achieve that goal. And he said no. And so that's actually very disappointing for me, because I can see the value in a safe injection site, but again, it has to be only an intermediate solution. So how is it that we can then work collaboratively between organizations in order to further help
that I
people?
think you have misunderstood his the purpose of Insight is not to tell people they need to get off drugs. It's to help them in that day. But there's an on-site detox treatment program that's actually based in the same building. So it does have the philosophy of these are opportunities to find ways to support people to get off drugs as well. But he was, I know, has been there as well many times, the philosophy in the injection room is not that we're going to tell you every time you come in that you should stop doing this. It's to, how are you doing today? Can we help you today? But there is definitely connections with allowing people to get off drugs, and there's even an on-site treatment program there. So we are looking at the whole spectrum of how we respond.
Thank you, Ms. Henry. We're going to move on to MP Don Davies now.
Thank you, Mr. Chairman. Thank you to all of you for being here today. It's very cogent, powerful testimony. Ms. Henry, we know that there's Dr. Perry Kendall, the Chief Medical Officer of British Columbia, has declared a public health emergency in British Columbia. He is quoted as saying an effective collaboration with the federal government could really have a major impact on reducing overdose deaths. I'm just wondering if you could briefly explain to us what led Dr. Kendall to declare a public health emergency in British Columbia, and ask you if you believe that we need a national public health emergency declared.
And that's a very good question. So I'm Dr. Kendall's deputy, and we made this decision in consultation with our colleagues on the coroner's service. We have a network of people that we've been watching this, and the reason why we declared an emergency is this graph right here, which shows that even though we had probably the best detection, monitoring, surveillance in the country for this, we were not making an impact. We had a take-home naloxone program, but people were still dying. 2 people a day are dying in our province from these overdoses. And so we felt we needed a much more comprehensive response, and we needed the ability to collect information that we couldn't collect under the current legislative framework that we had in BC. So having more data to help us understand who was being affected, where they were being affected, and where were the programs, where were the points of intervention that we could set up. And so it was partly to raise awareness and partly to give us those extra powers to be able to gather more information to help us respond in a more coordinated way. And the United States, the Surgeon General in the U.S. has sent out a letter to every single provider in the U.S. about the issues they're having. This is not something that we are the only ones being affected by. Canada has the 2nd highest rate of prescribing of opioids in the world. The U.S. is just ahead of us. There's a number of states that are having similar
Ms.
issues.
Henry, do you think we need a national public health emergency?
I do. I think, as my colleague, the coroner, reported, we are not measuring this across the country. It is affecting our entire country. I would like us to have a national approach to this, and I think the national leadership would be very helpful.
Thank you. Ms. Lapointe, the VPD has a policy of not attending at 9/11 calls for overdoses, and the RCMP testified on Tuesday that they've not even considered such a policy. Should they?
Absolutely. I heard our Minister of Public Safety say recently that we cannot arrest ourselves out of this situation. So we know that that approach, the shaming, blaming, arresting people, has not worked. It significantly has not worked. In fact, deaths have only increased and rates of overdose have only increased. Treating this as a health problem so that if somebody becomes ill from a drug, they call an ambulance and they're treated at a hospital is the only way that we're going to save lives, in keeping with the treatment aspect as well. If you develop a terminal illness or an illness that potentially is terminal, a cancer, for example, you expect that you will be treated and treatment will be available. If you become addicted to drugs, treatment should be available.
Now, let me pick up on that. Both Ms. Henry and Ms. Lapointe, I'm going to speak bluntly here. There seems to be a division in this room and with this government on C2. The government seems to stubbornly refuse to acknowledge that they need to make any changes to C2. Ms. Henry, the words you used were there, C2 contains extreme barriers. Hetty Fry, when she was the Liberal health critic, said that C2 was designed to avoid opening safe consumption sites. And I think Dr. Perry Kendall has said that too. So I'm going to ask you directly, the Liberal government seems to suggest the problem isn't C2, it's just explaining the requirements to groups, and if we can facilitate that, we can get more safe injection sites. Yet the facts are we have 2 injection sites in the country, Insight and Dr. Peters Center. Not a single site has opened in this country in the last year and a half. We have 1 application currently, and that's from the City of Montreal. And the Toronto Board of Health, everybody is telling me that the barriers, it takes months and hundreds of hours to get an application in. So I guess my question is, what are the barriers in C2 that you think are unnecessary?
Oh, I could talk for a long time on that. There's some of them outlined in the written report that we sent in. There's about 25 different pieces of C2 that I find are barriers. One of the key ones is requirements for opinions from neighborhoods that are not necessarily based on fact, and the types of opinions that need to come in. It's a challenge to get those because it reopens questioning around supervised consumption services and their worth, and it's a challenging part. The other part that I think is just ridiculous is you have to name every single person who will work in the facility, and none of them can have a criminal record or be so people like Sean would be excluded from working in a site, which we think is just ridiculous, because peer support is really, really important and helps. So there's a whole variety of them that I can certainly list for you.
Thanks. Maybe you could send those to the committee, all the barriers that you see. Because what jogged me was this connection of it being a health issue, not a policing issue. You have to get the approval of the local chief of police. What other medical or health service do we have in this country that you have to get the chief of police to sign? Shouldn't that be a medical decision, not a criminal decision?
I believe so, and it's the opinion of the chief of police, and I will say that we have had a lot of positive response from the policing services in BC, including RCMP division, and Health Canada has expressed through the Minister of working with us on trying to overcome some of these barriers, but we do still feel that repealing or extensive revision of C2 would be
Thank you.
Most appropriate.
Dr. Yearling, I want to give you a chance. You've talked about there being no national system of surveillance in Canada. Even the number of Canadians who die annually from opioids is unknown. You've talked about the CCSA. You've called that an inadequately resourced non-governmental organization. They've made 58 recommendations that you say have not been prioritized or been implemented. What can you tell us about those recommendations? Have they been implemented, and which ones do you think ought to be implemented?
I think some of them have. I have to direct you back to CCSA itself for the status of the various recommendations, but I guess my point in making that comment earlier was that 58 recommendations, by definition, some of them are more important than others. I mean, I got one in front of me here, okay? Improve and promote access to treatment, which should include pharmacological interventions, psychosocial supports, and withdrawal management programs. The proposed leads there are healthcare institutions. That can't happen fast enough. This is a 3.5-year-old document. I mean, it should be happening everywhere now. And so that's why I think that the assignation of priority was something that should have happened and did not.
Great. Thank you, Doctor. Thank you. Next is MP Sonia Sidhu.
Thank you, Chair. Thank you, all the presenters. I want to ask Dr. David, my question is that you mentioned the prescription, opioid prescription to the physician. What kind of restriction need to be done on when the doctors are prescribing opioid prescriptions?
So what kinds of prescriptions should be implemented for physicians? You'll get very
so
different...
what kind of restriction need to be...
Restrictions?
Yeah, on the physician when they...
Are you asking what restrictions I would advise?
No, any preventive measures, like can you talk about that? You said 1 in 8 deaths involved in Ontario.
Yeah.
So what kind of preventative measures you are thinking, like the physician cannot prescribe the higher opioid
I think there's slightly different constructs, but from the prescribing perspective, I mean, I think, you know, as a physician, I am conditioned to want to help my patient, and I see pain all the time, and I'm scared of the other drugs, and I've become comfortable with opioids because of what we've been taught, much of it untrue. What I'm saying is that I think physicians need to be re-educated, de-educated about these drugs.
What kind of education, like, do you think, what kind of education need to be?
Education should focus on the fact that the goals of a drug are to impart more benefit than harm, and opioids very frequently don't do that. I mean, they can in some patients in the long term, but the higher the dose goes, the less likely that is to happen, and that's why I think doctors shouldn't be allowed to prescribe ridiculous doses, 200 or 300 milligrams. It's inconceivable that someone is benefiting from that. And I also think that these high-dose formulations that are out there, that like the Oxy Neo 80 and the high-dose fentanyl patches, when they are used as directed, you exceed the threshold dose from the old Canadian guidelines, the dose above which it's very likely that harms exceed benefits. I mean, that just shouldn't be happening, and yet it still is. It's a cultural thing now. We've been doing it for 20 years, and we have to stop doing it.
Okay. Mr. LeBlanc, you said we need to educate our kids for harm reduction. What age need to be? Is it in elementary school or in a middle school?
Well, I see it, at least in Ottawa, children as young as 13 even getting into fentanyl. There seems to be no progression where when I was a youth, people who'd start at marijuana and then alcohol and kind of progress their way up. They're starting at fentanyl and these hardcore opiates at a really young age. So yeah, I would say junior high school, grade 7, grade 8.
Okay, thank you. And Ms. Lapointe, you said language, and is there any strong language you said in the heroin? Did it any impact on the crisis? Is there great impact, the language you said when, can you outline any other example how language and definition have impacted on the crisis, which is BC?
So what we have heard, and again, I'd like to emphasize before I answer that, we have a dearth of research in this area. So we do not have evidence across the country as to exactly who's dying, when they're dying, why they're dying. So we don't know, for example, how many people who are currently dying were prescribed opiates. If you're going to implement evidence-based solutions, you need evidence, and we do not have that. And I would certainly call on this committee to seek some investment in the research. So to answer your questions, one of the things we hear anecdotally from those who are working with those who use illicit drugs is that the language around stronger drugs, more powerful drugs, will cause a certain segment of the drug-using population to seek out those drugs. So what we're talking about is people who are now actively seeking fentanyl because it's a better high, because it's stronger than the heroin they've been using, for example. But I also want to be clear that the drug deaths that we're seeing in BC are not just opiates. Cocaine is also often involved. Alcohol is often involved. And again, we are starting to attempt to do that research to pull out what are the different substances, but without knowing exactly what substances are killing people and how they started to use those substances, I would argue that we really can't implement any meaningful solutions.
Okay, thank you. I want to pass my time to Mr. Sprague.
Absolutely.
Thank you all for coming. In fact, I've sat on several committee meetings, and I'd say if there's anybody 19 to 39 or a parent and they will have to watch a standing committee, that the 2 hours on this would be probably their most valuable time ever spent, getting a range from people dealing with them daily, to the people who prescribe them, to the people who see the health emergency in British Columbia, to unfortunately the people at the end of life who see them die. This is probably the most profound panel I've seen on this issue. What I would like to know, and so I want to commend you first on that, Dr. Jerlink, if you can say what's your suggestions of the benefits of a supervised consumption service site in avoiding this opioid crisis?
Invaluable. People are always going to use drugs. Not everybody who has an addiction wants to keep using. Many of them want out, and they should be given the opportunity to get out. But it's simply a fact that people do not die in safe injection sites. And there should be, I agree with Sean, I mean, there should be one in every community in this country. And any barriers, as the barriers are there, and the wheels turn to try and get approval, I mean, people are dying in public bathrooms. Shouldn't be happening.
Dr. Henry, what's the percentage, do you think, in British Columbia that of the people dying from this opioid crisis are prescription-based addictions versus recreational-based addictions? Do we have any data even?
We don't have data on that, though I can say that the crisis in BC has evolved, and it's slightly different from what they're seeing in Ontario right now, where it's generally not prescription opioids that we're seeing as the issue. It's illicit opioids that are on that people are buying on the street. And so it may have started with some diversion of illicit fentanyl, but clearly the issues right now are around illicit fentanyl that's being manufactured mostly offshore and imported into BC.
And are there any detection devices if somebody went to a safe consumption site and wanted to test their product that they're using that can see the level of fentanyl or if it is laced? Is there any technology like that out there that would be helpful that we could have in places such as a safe consumption site where somebody can test their product real quickly to make sure they're not ODing on this afterwards?
So the short answer is kinda. There are ticket tests that we've done a pilot of at Insight that are they're like those pregnancy tests. There's little bars, and they tell you if it's, but they can only detect fentanyl, not some of the other illicit opioids that we're seeing out there, and we don't know how well they work. So this was just a pilot. Some of the challenges we're having is under the Controlled Drugs and Substances Act, the people who work at Insight cannot handle the drug. So the person themselves has to test their own drug, and it's a little bit tricky and complicated, and it needs some help. There are some machines, mass spectrometer machines, that can do a better job at detecting what is in substances, but again, they have to be used by somebody. And so that's where we think we can get helpful exemptions under the Controlled Substances Act to allow that service to be available more widely in places. So it is illegal for me to test your drug for you at the moment.
Great. Thank you, Randy. Thank you. Okay, we'll move on to our second round. We've got 5 minutes each. We'll start with MP Dr. Colin Carey.
Thank you very much, Mr. Chair. And I did want to bring to the attention of Ms. Lapointe and Ms. Henry there. You mentioned about the pill presses and the precursors for fentanyl. I know one of our colleagues in the Senate, Vern White, has actually had 2 private members' bills moving forward, and I think he's had discussions with the minister. So I think we're trying to expedite moving that forward. I'm going to take a contrarian view. May not be popular with this panel, but like Vern White, he comes to the issue and he takes into account the public safety point of view as well focusing on treatment. So maybe I'll start with Madame Henry here. You know, we talked about how we don't have good statistics, and even the statistics at Insight, you know, they're the questionnaire type of statistics, and from their website, they say only 7% of users of Insight actually go on to on-site, and their statistics are only 50% stay with the treatment. So it's very, like 3.5%, even with their own statistics, go into the treatment, and then how many of those actually continue on afterwards, we have no idea. And you're calling for, you know, the repeal for the Respect of Communities Act, you know, the Respect for Communities Act. And I'm just finding that it seems that this very unique situation in Vancouver at Insight, and I think before Insight it was very unique and it was an extreme situation, and even with Insight there, I've visited as well. I think it's still a very extreme situation. It's very sad when you actually move through that area. But when you said communities, you know, shouldn't they have an opinion? I want to quote somebody who takes a different viewpoint. His name is Bill Blair, and when he was a police officer, now he's a politician, he actually said, they've been doing this in Vancouver for some years, and there have been some issues that have arisen there. I don't know of any place in Toronto where they couldn't have had a significant negative impact on the communities. He also said about the education part of it, the ambiguous messaging that comes out from a society that says you can't use these drugs, they're against the law, but if you do it, we'll provide a place for you to do it. And he's got some other quotes there. Do you actually think that communities shouldn't have an opinion, shouldn't have a say? Because I would think the success of a supervised injection site, if the community doesn't support it, it won't be successful. So calling for the repeal of that, is that really what you think?
Yeah. I think communities absolutely have to have an opinion, but it needs to be an informed opinion and informed on the evidence. And there is a lot of evidence around Insight and the effectiveness at Insight, not just at saving people's lives, but on the impact on crime, the impact on the community. And you're absolutely right. The downtown east side in Vancouver is a community like no other, thankfully, in this country. And there are many, many challenges in that community. I think the model of Insight as a standalone safe injection site is not what we're looking at in many communities. What we're looking at are what we're calling safe consumption services. So the ability for people to use in an environment where they can obtain the help they need if they need it. But I think we miss the part that our very first message is, of course, that this is dangerous and you shouldn't do it. But as Dr. Jerlich says, people are going to use drugs, and what we have to do is provide the opportunity for them to stay alive long enough to reach their potential in life. And I think safe consumption services do that, but they need to be integrated into the health service system, into areas. The Dr. Peter Center is another good example of this, where they're very quietly within the provision of other health services. It's been a very effective service. And so we've done a lot of work with our law enforcement colleagues in BC, and they have talked to the Vancouver Police Department about how well this is working, and people's ideas have changed, and what they need to be is informed about the effectiveness of these services and how they benefit communities.
Well, that's what I'm talking about, informed and good data, and we just said we didn't have it, but Insight keeps being held up as the you know, this is where we want to go, or this is kind of the flagship of Ontario or for Canada. And what I'm saying, like, I looked at the literature, and it seems that it's written by one or two different guys that keep quoting each other. There's a guy named Kerr, there's a guy, I believe his name is Mortimer. And when you're looking at it from a government standpoint, it seems to put all the eggs into one basket with injection sites. If you look at the costs, and I believe it was the Police Association president was on CTV saying at Insight they've had to divert 100 officers to police and make sure that that area is safe for people that are down there. At $100,000 per officer, that's $10 million per year, which if you look at treatment beds, that could treat over 1,000 people, 90-day treatment programs.
Dr. Kerr,
so,
your time's up.
Well, just want to make sure informed and good statistics. Is there any out there?
I think there is some very rigorous research that was done around Insight, and Dr. Kerr is one of the lead researchers in that. Those are independent research grants that he received. So I think we have, but as I mentioned, there are many different models that we're looking at around safe consumption that are integrated into health services and the continuum of services for people, including treatment options.
Thank you. We'll go on now with MP Dr. Doug Lawson. You've got 5 minutes. Thank you.
Thank you, Mr. Chair. Thank you all for coming. This is very valuable. As background from some of my questioning, I'm an emergency physician. My entire career, it was in emergency medicine, the last 8 years in the inner city of Winnipeg. This kind of subject has been near and dear to my heart as it occupied a great deal of my professional time. Dr. Gerling, I really appreciated the comments you made about physician prescribing practices. I see people come in, we get a computerized readout of what they are, people are prescribed. It astonishes me what people are being prescribed, and when they run out of their medications, they come to emergency because they've run out, my doctor's offices is closed, or worse, my doctor is refusing to prescribe these anymore. Can you do it? We have tried to get intervention from the College of Physicians and Surgeons in Manitoba to have some sort of prescribing guidelines and restrictions as to how prescribing practices can be more controlled. And they've more or less turned a blind eye to it. They say, well, no, we're not in the business of just micromanaging how physicians practice medicine. So would you think that the colleges, the regulatory agencies in each province could have a greater role in helping to change physician behavior and prescribing?
Yes, I do. I think BC has already done that. In fact, the CDC in the U.S. earlier this year introduced prescribing guidelines, and I think BC has mandated their use. There's some danger in that because those guidelines don't deal with the people on hundreds of milligrams a day, and those people, when cut off suddenly, will go to the street and they'll die because they've got something with fentanyl in it, for example. I think that it is, as someone on the steering committee of the new Canadian prescribing guidelines for chronic pain, I think it's important that every provincial and territorial regulatory agency strongly encourage, if not actually mandate, that the guidelines that come out in early 2017 be followed.
Mm-hmm. Thank you. That is what I had always thought should be the case. Nice hearing a voice that is supporting that. Okay. Now, Ms. Henry, one of the things we talked about, and this was alluded to by Mr. LeBlanc, and thank you for your courage in showing up today and sharing your story. We talked about the justice system. The justice system, many people who use drugs end up in the justice system. A lot of people are in the justice system with addiction issues, and the justice system just has woefully inadequate treatment facilities. Now, would you agree that we need better drug rehab in our correctional system?
Absolutely, and that one of our partners in our response is our correctional services, the provincial and federal correctional services. So we've started with naloxone and making naloxone available in our provincial corrections facilities. Treatment availability is being worked on. So these are really important issues. We do see, as was mentioned, a critical period when people get out of a correctional facility and they have not had access or not had regular access to drugs in the facility. They're at a high risk of dying from an overdose in that period of time, so supporting them around that period of time. We also hear in the correctional facilities themselves that because drugs apparently come in quite regularly and people need to use them all up very quickly prior to them being detected. So there's a high rate of overdoses happening in our facilities now, and how to manage those appropriately and how to encourage people and provide the opportunity for opioid substitution and treatment while in prisons is something we think is really important.
Thank you. I've got 1 minute left. I wanted to just go further to that. One of the benefits of a program like Insight, in addition to preventing overdoses, of course, is they're provided with clean supplies, clean needles, which means that you're also decreasing the rates of disease, bloodborne disease transmission, HIV and hepatitis. Now, several months ago, it was brought up in the news that they're refusing to have anything like needle exchange programs in prisons because of a, quote, zero tolerance. Would you agree that a harm reduction program needs to be introduced to our correctional system?
Absolutely. That's something we've been advocating for some time, and we think harm reduction is one of the important pillars in this response, and it should be in our correctional facilities as well.
Okay. Thank you very much.
Great.
I've only got 5 seconds.
You've got 5 seconds. I'm sorry, Doctor. If you could spit a question out in 5 seconds, I would be impressed. Anyway. All right, we're going to move back to the Conservatives, to Dr. Carey. You have 5 minutes.
That we're going to split our time between myself and Madame Harder. So I'll take one question, and Dr. Gerling, I think you hit the nail on the head of one of the real challenges, but you've said some controversial things. And again, I'm just going to be the contrarian because this panel, normally we have different viewpoints on a panel, so I'm going to try to give you a hard time. I don't think you'll have a hard time with it, but you said the crisis is created by physicians. We basically have to stop prescribing these drugs because physicians are conditioned to help, and I think that's a really good thing, and there's been studies out there that actually show that. But when you mentioned the opioids on the market, when we were in government, I know we got criticized significantly by former Liberal Health Minister in Ontario, Deb Matthews, the American governors, by saying that we should be taking a federal approach to make all these opioids tamper resistant, because if they are going to be prescribed, make it so that it's a very small population that should do that. She also said that one of her First Nations community, I believe her quote back then was like 78% were addicted to opioids. And the comment that really scared the living daylights, I think the chief said, the drug pusher in my community wears a white coat. So what do you think about this whole issue of if they're going to be prescribed, and Mr. LeBlanc said, for some conditions, and I've had people come to my office to say, fentanyl kind of makes me be able to function in my day-to-day when it's prescribed appropriately, whatever, we can argue on that. Should these drugs, the entire class, make it more difficult that they can't be tampered with and make it more restrictive for physicians prescribing them?
So just to correct, I think you quoted me as saying that these drugs shouldn't be prescribed. I didn't say that. They have a role.
Yeah.
I think abuse deterrent formulations are a good thing generally. You can crush them and you can chew them and you can get a much higher level in your blood than you would by taking them intact, but you can't powderize them and inject them or snort them. But it is a mistake to think that this is the way out of this problem. I mean, these products tend to materialize on the market as the patent on the original product expires. And so a cynic might wonder if this is primarily a business decision, just saying. But the fact is that the primary route by which opioids are abused is oral. And so and I know for a fact that physicians, when they hear about these abuse deterrent formulations, they think that they are somehow impervious to abuse. They are totally abusable. And so I'm in favor. If you could snap your fingers and have them all be abuse deterrent, great. It is not a major part of the solution to this problem, in my view.
Sure. I'm just wanting to create a bit of a framework for this epidemic that we're seeing, and so I'm just wondering if Ms. Lapointe, you might be the best one to answer this question. I'm just wondering if you can comment with regards to the demographic that we're looking at. I know that it was mentioned that it's more male than females, but I'm wondering, is there a specific ethnicity that we're seeing this, at a higher percentage? Yeah, that would be question number one.
We don't collect data around ethnicity, so I can't tell you that. We have started collecting data for the First Nations Health Authority in British Columbia, so we will be able to report out at some point around the number of First Nations people or Indigenous people who are dying. But the demographic, for the most part, as you said, male, 29 to 49, and sometimes a little bit older, and all walks of life, but primarily we're talking about people who have used illicit drugs for a long time. And as I want to be clear, our criteria only includes illicit drugs. Prescribed drugs are not included in these deaths.
Okay, thank you.
That just because we have been collecting data on people who are surviving overdoses, the picture that we're seeing of survived overdoses is different. So we're seeing, at least in some parts of the province, and what we're seeing is geographic differences as well. So in some parts of the province, it's more equally weighted, boys and girls, men and women, and they're more often associated with not people who are chronic, long-time users, but people who are more recreational users, and often in private homes rather than in public places. So there is a difference. And so that's why this data is so helpful for us in looking at points where we can intervene to prevent ongoing drug use in people.
And between between the two of you as well, maybe you could also answer this question, and that is, I guess there's two parts to this question. One, I'm wondering why the province of BC is so hard hit, if you could reflect on that a little bit, because that seems to be exponential numbers in comparison to other provinces. And then my second question as a part of that is, why such a drastic increase in the last 5 years? Because when I look at that map up there, when you show me the colors, I mean, that really hits home for me. And so I really would love to understand, why has this become such an epidemic in the last 5 years?
So you only have a problem if you know you have a problem, is my first response. In that the BC Coroner Service has adopted a fairly risk-tolerant approach to reporting this data. So we get the data within 48 to 72 hours, and we are reporting these deaths monthly. And you will not see that across the other provinces or territories. They do not collect the information the same, and if they do, they're not reporting it the same. So the surveillance that we're doing is letting us know there's a problem, and we may find that out in other parts of the province months or years from now when the data is rolled up. So that's the first part of it. In terms of the increase in deaths that we're seeing, fentanyl is driving that hugely, and I would say that because we are on the coast and a great deal of this product is coming from China, it's hitting our ports and it's moving into our communities that way, and I think that is also why Alberta, you see BC, Alberta, and then it may lead. If I could, I wanted to mention, you talked about treatment a few minutes ago, and I didn't want to leave that because I do want to advocate for treatment. We see from families who we talk to who have lost their loved ones that they have banged their heads against brick walls for months, if not years, trying to get appropriate treatment for their loved ones. And there is a time when somebody who is using, Sean may be able to talk about this better than me, when they want treatment, they want to get off, and that window is small, and if that treatment is not there when they are ready for it, then they will go back and they will die, or they will continue to use, and the window is lost. So you're absolutely right, treatment is a critical piece of this, and it has to be available for people, and it has to be at no cost. We also know that families have spent tens of thousands, if not hundreds of thousands of dollars trying to access treatment for their loved ones, and not everybody has that kind of money. So that was a very good point. Thank you.
Thank you. We'll move on now to MP Darshan King. You've got 5 minutes.
Thank you, Mr. Chair. Thanks to panel members. We were talking about prevention and education. I know an organization in Calgary, Drug Awareness Foundation of Calgary, and they've been doing open houses, trying to educate people against drugs. And every time they have a open house, and the concern comes out that when we try to educate people, don't use drugs against drugs, that may encourage young people to try drugs. It's becoming kind of double-edged sword. So you think we are doing something on the prevention and education side in a proper way, so we don't encourage youth to get into the drugs.
So
maybe
I'll start with that. We see from other things that we've done. So we look at how we've educated children around alcohol use. And we see alcohol use actually decreasing in teenagers from studies we've done in BC. Around cigarettes, smoking is just not done anymore in that age group. And when we've talked to students about these things, we've talked to them about marijuana, for example, and we've talked to them about drugs, and they say, oh, we never hear anything. So the information we get, because we don't get it in a formal way in our schools and we hear about it on the streets, we hear that, we hear untruths about it, and that is what makes it tempting to us. So I think we do need to talk to people in a very forthright and open way about drugs, about their uses, their benefits, their harms, so that they can make those informed decisions. And we've seen when we do that right, it works.
So is there enough getting done? Because it took 5 years here to come to this fentanyl crisis, And couldn't we see it back then, like that that's maybe a crisis in the it's brewing, and is there another drug on the horizon you think could be after this one? Are we being vigilant about any other drugs?
You notice there was a peak in the 1990s, and that was when crack came into BC, and that peak was mainly confined, and because we've been looking at it for some time, that was mainly confined to the downtown east side, and we were seeing a lot of people dying in that. And so the response was quite different. And we have a partnership in BC that has been going and looking at this data, thanks to the coroner's office and others, for a number of years. And so we did see things coming up. Where we finally reached the point that it was that we declared the emergency was because all of our usual measures to try and intervene, increase awareness in the street, make sure people know what's happening. We've had a number of campaigns. They weren't going anywhere, and we needed a much more broad partnership to try and address these crises as the deaths were coming up. So
why is it right across the province? I mean, any reasons? Why? That's mind-boggling. Like, it could be, say, downtown center, downtown in the city, or but it's just right across the province.
And it's the drugs that are being used now. The opioids are being used across the province. We've seen issues related to economic conditions in certain parts of the province that have led to increased use. So there's a variety of factors that have led to it, but I think it was understanding that it was no longer confined. It wasn't just a problem in one part of the province was one of the reasons that we declared an emergency to address it.
Okay, we've been talking about Bill C2, and my understanding is, I just want to make a comment. The Minister of Health, I think she's going to look at the barriers in Bill C2. That's my understanding. I just want to make a comment on that. And Dr. Jurlik, the patients, you said something about the doctors prescribing medications. I know somebody, and like some patients, they will go to doctor to get Oxycontin, say, per se. They will get that, and then they will sell them too. And how can we control the abuse? Is there some kind of mechanism in place that doctor knows that there's
stop that problem, but we can take lessons again from BC, which in the mid-1990s began a program called PharmaNet, and almost overnight every doctor, every pharmacist had access to real-time data. So if you got a prescription in Richmond and the following day you got a prescription in Burnaby, the person looking at the prescription profile would know. And we showed some years ago that was associated with a very rapid and dramatic drop in double doctoring for both opioids and benzodiazepines. That should be in existence. That sort of model, all drugs, all people, should be in existence in every province and territory in Canada.
Great.
There's no good argument against it.
Thank you, Doctor. Our final questions today are with Mr. Davies. You've got 3 minutes.
Thank you. A few years ago, the Public Safety Committee did a study on the rate of addiction and mental illness in the federal correction system, and the conclusion we came to was that 80% of inmates in the federal system have an addiction. Would an increased use of drug courts and treatment diversion programs in the justice system be a positive measure to help people entering prison perhaps have a chance of dealing with their addiction?
Well, that's a very good question, and there is a drug treatment court in Vancouver, and I haven't seen the data coming out of that, but I know anecdotally from those who work in that field that they believe it's very successful. I can tell you, I have worked in the provincial correction system, and at the time I was there, which was in around 2006, 7, 8, we found the same. 63% of those in jail had either a substance abuse and or a mental health disorder, or on generally both, and very challenging treating those with substance abuse or mental health disorders in jail. it's not an optimal place for people. And again, if you want to adopt a health approach, if somebody has an illness, putting them in jail isn't really the best way to treat them. So absolutely, we need to be looking at novel ways of treating populations that really are just going to cycle back through the jail.
In your experience and people you know, if people were facing a criminal charge and they had an addiction, if they were given an opportunity to avoid the correction system and go into treatment, would that be something that, in your experience, people would choose if they had that opportunity?
I think so for the most part. I think it needs a bit of tailoring, though. The drug court right now is pretty well abstinence-based. When people are failing, they're still being punished for their original crimes. A lot of cases, though, it's worked really, really well for people. There are a lot of limitations, though. People can't work while they're on it. People aren't able to attend school while they're on it because of the time commitment involved. I think, we'd make a couple adjustments and it'd be even more successful.
Dr. Yerling, I want to come back to you. When you said there is no national system of surveillance in Canada and even the number of Canadians who die annually from opioids is unknown, how do we fix that? Who should be collecting the data and how do we do that?
You need data on deaths and data on non-fatal overdoses. The data on deaths should come from the regional coroners, who should be empowered to collect data in real time and report it in real time. You can't fix what you're not even measuring. The non-fatal overdoses should come, I think, primarily from CIHI, which contains national records on emergency department and hospital visits. And those two things together, I think, will give you a pretty clear picture of the problem.
So,
more to add to that? No, that's true.
And it's not universal across the country from emergency department data, but it's a start.
I know there's a summit in November, but it sounds to me like the Joint Task Force in British Columbia has come up with some great recommendations. Do we need a national joint task force made up of the federal government, all the provinces and territories to get a handle on this Canadian issue?
Yes.
Yes.
Yeah. Great. Thank you.
Yes, and I think, first of all, I don't want to harp on this, we need to establish criteria because we don't even know across the country that we're talking about the same thing. So is the data that Ontario is collecting around fatalities the same data that BC is collecting, the same that Nova Scotia is collecting, the same that we are all collecting? We need a definition that is standard, and that I think needs federal leadership to define. Here's the definition for the information we want to collect, and then the provinces and territories can start to collect it.
Thank you all very much.
One very quick point. I mean, every hospital in the country could have a person who is empowered to each week report the number of drug overdoses that came to their emergency department. Easy. They report all kinds of other things that are far less important. It would not be hard to do.
I would say that we need to have a definition. What is a drug overdose?
That's
is it a
fair.
prescribed overdose? Is it an illicit opiate overdose? Is it a cocaine overdose, a stimulant overdose? Those are all different substances and they have different solutions.
I agree.
So definition
Mr. Chairman, I think we have our joint task force sitting at the table here.
That's the truth, yes. And unfortunately, we have to end our witness session here. I want to thank you all sincerely for being here today. You were most informative, and thank you so much. We have to move on to some committee business. You're welcome to sit through that. It's quite related to our topic here today. So you're welcome to stay if you wish. Ms. Sidhu, last meeting tabled a motion, and she wants to bring that up now. What I understand, would you like to read your motion over again, Ms. Sidhu?
Yes. Thank you, Mr. Chair. As I gave notice of my motion last meeting, today I'm moving my motion. I think this motion reflects what we have heard from witnesses, that pursuant of Standing Order 108, the committee call upon the Minister of Health to move as quickly as possible to conduct a review of the laws and legislation in place with regard of safe injection sites.
Excuse me, Ms. Sidhu, can I just interrupt you for a minute here? We've got a bit of commotion here right now. Perhaps I might start this in about a minute or two. We will let we'll start in 2 minutes. Thank you. I'd like to call the meeting back to order, please. I am, again, I'm sorry, MP Sidhu, for interrupting, but we will get back to your motion here again, so please, if you can continue.
Thank you, Mr. Chair. As I gave notice of my motion last meeting, today I'm moving my motion that pursuant of Standing Order 108, the committee call upon the Minister of Health to move as quickly as possible to conduct a review of the laws and regulations in place with regards of safe injection sites. This review should have as an end goal to improve the health and safety of Canadians using a strong evidence-based approach.
MP Sidhu, we have been any, I'll let Dr. Carey talk first here.
That I did, Mr. Chair, find this motion quite unusual because the minister can already do this at her discretion. I would have thought that she's already reviewed her files that she has in front of her. So call me old-fashioned too, but the comment here was safe injection site. I don't like that term safe. I think we've heard that really there's no way to safely inject street heroin that could be laced with whatever off the street, could be kerosene into your veins. It's not something that's safe. So I would like to propose a friendly amendment if we are going to go this route. I think, like I said, the minister can do it anyway, but I would like to say, let's say after the second sentence, this review should, and I'd like to add, be reported back to committee. Like if the committee's asking her for this, it would make sense to me that we actually get a report from the minister so that we can see what she said, and have an end goal to improve the health and safety of Canadians using a strong evidence-based approach. And I'd like to also add that strengthens consultations with communities who will be affected, because I think it's really important if you want to have some success, you have to have communities that are supportive. So that would be my attempt at improvement.
Okay, so you put forward an amendment to the motion to change the wording in here.
And I'd like, sorry, one other thing. Instead of safe injection sites, could we say consumption sites or something like that? Change that word, because there's nothing safe about it.
All right, we'll go Mr. Davies.
Yeah, in terms of the latter, sometimes we use the words supervised consumption sites. Is also, I think, an adjective that we can use. The other kind of amendment that I kind of think ought to be made is to strike the word "and safety" out. We're the Health Committee. If we said this review should have as an end goal to improve the health of Canadians using a strong evidence-based approach, that's the point of this. And I think we've heard our witnesses testify over and over again that really the point of this bill is to make this a health decision, not one that's diverted into issues of criminality or safety. So I would just say, and in fact, to be honest, I think the concept of health embraces safety.
Okay.
So I would move to strike the words "and safety."
Right. Mr. Davies, we're going to go on the amendment to his amendment first and vote on that. But Mr. Carey, you
appoint. We had health officials here, and the mandate of the minister is the health and safety of Canadians. So to remove safety, that doesn't make sense to me. For asking the minister.
All right. Mr. McKinnon on the amendment to the motion.
Yeah, I think Mr. Carey, Dr. Carey, I think we have three separate amendments here. I would suggest that raise them as three separate things.
Yes, absolutely. And we do have 10 minutes, so let's deal with the First Amendment.
I would suggest the First Amendment that you're proposing would be to change safe injection sites to something such as supervised consumption sites.
That's what you
That's fine.
indicated?
Yeah,
okay.
I'm fine with that if you guys are fine with that.
And then at the end, you wanted some...
One would be to report back to committee.
To report back to the committee, that's the second change there. And thirdly...
Third one, add that strengthens consultations with communities who will be affected, because once you have an injection site in a community, it can change that community forever. So I think it's important that they have an opinion and a say.
Any comments on the amendment?
I'm sorry, what is that amendment? I'm a little bit behind. We've got the supervised consumption site, and then, Colin, you wanted to have a report back?
That'd be the second amendment then.
Okay. And what's the third?
At the very end, that strengthens consultations with communities who will be affected.
So, Mr. McKinnon, you have a sub-amendment to the amendment?
So, am I to understand this is one amendment to make those three changes?
For maybe to quickly get through it, because we're actually over time already, and I have another thing to go to. My first one, if it's unanimous, I'd just like to scratch safe injection sites and put supervised consumption, Don's wording. Is everybody okay with that?
If that's a separate amendment, I support that.
All right.
Can we have a vote on that one amendment then?
You know what?
Please, yes, that would
Sorry,
be nice.
you know what? I'm just told I'm going to have it just as one amendment. Let's just vote on it.
Yes, absolutely.
Yeah, I've got.
That are very different. We need to report on. We need to.
All right.
Do you want to know? I put the amendment forward originally, and Mr. Chair, unfortunately, we are overdue.
Okay, we'll vote on the amendment.
Then we'll vote it down.
The three changes in the amendments. The supervised consumption sites, also the addition of be reported back to the committee, and then thirdly, that, I'm sorry, what?
It strengthens consultations with communities who will be affected.
Okay. Over here. So we're going to vote on that amendment to the motion. If you're in favor of the motion, the amendment to the motion, please show your hands, please. Okay, and if you're against the motion, please raise your hands. All right. Well, the motion, the amendment to the motion has been defeated. Mr. McKinnon.
I'd like to move an amendment to change safe injection sites to supervised consumption sites.
Okay, all right, we will vote on just that amendment to the motion. In favor of that motion? And opposed? Okay, it's been passed. That change will be made.
Then they should vote on the main motion.
Mr. Davies? Then vote on, yeah.
The motion that obligated the minister to report back to the committee on the result of her review.
Okay, can I get any discussion on that?
Right. By the way, I mean by that, I don't mean her personally. I just mean that we get from the minister's office.
Okay, then I guess we're prepared to vote for your amendment to the motion. In favor of Mr. Davies' motion, can you show your hands? Okay, opposed? All right, that one's passed. So now we need to move back to the original motion if there's no more amendments to the motion. So the motion that has been amended, the motion put forward by Ms. Sadhu, are we in favor of the motion? Please show your hands. And opposed, show your hands. Thank you. It's been passed. So the motion has been passed. Thank you. So now we need to go in camera to talk about. Okay. All right. Well, we don't have time then to go into camera, but to discuss our future meetings, when will we have time to do that then, Mr. Clerk? So we've got a list of presenters here prepared for our next meeting. We will invite them to be here, and at that time we will then discuss our future meetings down the road.
And perhaps, Mr. Chair, we've been circulating amongst the members of the subcommittee on agenda and priorities. We can continue the discussion of that at that level as well, I think.
Fantastic. All right, then I'll adjourn the meeting. Thank you. Mr. McKinnon?
At some point, I wanted to suggest a couple of witnesses for you. I can do that offline if you prefer.
Certainly, yes. If you can just bring that to the clerk and we'll put it on the list. Thank you. The meeting's adjourned. Thank you.